Hi everyone, I'm Justin Schrager. I am the Chief Medical Officer for Vital Software. I'm an ER doctor. And I appreciate y'all having me. So what I'm going to show you is very, very, very different than what you've seen so far. So it's not new models of care. This is something that patients use when they're in the hospital. And then there's a component of it in which we help the patients and the hospitals and the people that are in the community take care of the patients communicate with each other. Okay? So I think the reason, I'm not totally sure the reason you invited me here, Larry, but I think this is sort of like, this is a crazy idea. What we're doing in the acute care setting is, well, I'll just show you. So it's not something that really exists. So there's nothing like this. As far as I know, there's, Epic has MyChart where patients can kind of log in and do things in there while they're in the hospital or in the emergency department. But we don't have a ton of competitors, but how many of you stayed in the Omni last night? Were you getting text messages from the hotel about like getting your bags taken downstairs and stuff like that? Okay. So that's like a usual experience that people have in the consumer world nowadays. So you can see your packages being delivered, you can see your pizza being cooked, you know, you can check into everything on your phone. So that's basically how the normal modern consumer lives. And so you can think of this software as sort of like that, but for the hospital, okay? We have a few different software platforms. We sell it under a white label program, so effectively our customer is the hospital. They pay us for SaaS, software as a service. We hook our software up to their electronic health record. We take the data out of the electronic health record, basically all of it, all the important stuff. We process it through a variety of things, everything from simple algorithms that go into the user interface to advanced AI modeling, generative AI. We do a bunch of interesting stuff for the patients, and then we give it back to the patients on their phones. Okay, so that's how it gets used, and we have it from the start of the visit to the end. We've been doing this for about 6 years, really about 4 years concertedly. We're in about 140 hospitals now. We have about 1.1 million patients using it per year, and I mean it's a for-profit company, and we have about 90 employees. So it came out of Emory, which is where I used to work. I currently work at IU in emergency medicine there, and these are our customers. You can see there's a bunch of different stuff it does in there. So it has different value for different people. So the health systems like it because it shows patients, it keeps patients happy. It's a good thing for marketing. It's a good thing to treat people nicely, keep them updated. But what we do a lot of is sort of helping their patients get linked back into care after they leave the hospital in an intelligent way. So it's sort of the opposite of what everyone's been talking about here, which is like keeping people out of the emergency department. The reality is that people come to the emergency department with acute medical problems, and for about 2/3 of them, they're getting an entire month's worth of a primary care workup in about 2 hours, right? And then I'm sending them out with gallstones and a $3,000 bill, and I'm telling them, hey, you need to go find a surgeon, or you need to go back to your primary care doctor, or something like that, as you all know. What do we do with the software? Well, basically what we're trying to do is give patients control over their visit. We're telling them what's coming up next, we're giving them AI-based education, we're telling them how long we're going to be in the waiting room, things like that. And we have had some pretty good outcomes, particularly with Common Spirit and a few other health systems. And what we really do is improve their patient experience scores, stuff like that. Of course, patients are happier if you keep them informed. But we also do downstream revenue and things like that. You can read it here. I mean, it's interesting. We look at different KPIs with, or value on investment metrics with each different customer, depending what they're interested in, whether it's their scores or Google reviews, or it's sort of like downstream revenue from referrals and things like that. What I'm going to do, since I'm trying to read the room a little bit here, is show you guys a demo of how it works. I think it's going to be probably the most instructive. Let's see if I can zoom in a little bit. The Wi-Fi in here is a little spotty, so.
If you do Control+, it should zoom.
Okay.
For the Apple custom.
Yeah, so it's also I just switched it over to Apple computer, so that's fine.
So right now it's big enough as is. You can go.
What's that?
It's big enough as is right
Oh,
now.
you can see it? Okay. I
You
mean,
can't see necessarily the print.
you
for
can't
everything,
read the
but,
print,
yeah.
but that's okay. You'll be able to see it. All right. Well, let's just proceed as if you didn't have seen it. So the way the software works is that if you checked in the emergency department, you give them your ID, they ask you who you are, they validate you, and they create an encounter for you. Our software doesn't start talking to patients until they come into the acute care setting. Okay, once they do, we invite them to use the platform. They don't need to be on the Wi-Fi. They don't need to download anything. They don't need a username and password. And we will translate the content of the application for them. Like you, like zoom this thing. This might be a little better for you in the back. And then when people log in, this will be a translated experience for them. If they speak Spanish, if their phone's browser is set to Spanish, or if it's listed in the EHR, it will be automatically translated. And I'm just going to breeze through this because I don't have time to go over all the vagaries of it, but effectively what the patients are going to get when they check in is they're going to have wait times presented to them. This is an AI model that we use. It's a multi-level machine learning model that does. It uses queuing theory, so basically we can tell how long people are going to be in the waiting room. And it's based on what's happening in the department and how long they're going to be there, and it's based on individual level characteristics as well. How old they are, what they're there for. We have educational content about like, why do I have to wait when this person doesn't have to wait. We have tips that the nurses write. This helps with sort of like operational throughput in the department. We have family sharing, which is, I think it's pretty fun, but basically the patients in the hospital can click on sharing. We'll bring up the system share dialogue on their phone. We'll write a text message for them, and they can send it to someone who's not there, who can follow along with their visit. I'm sure this is something that you all have experienced. If you have a family member that went to the ER, it's like, why isn't the ER doctor calling me? I'm a primary care doctor, he should be calling me. Of course I should be calling you, right? It's like, I'm busy. But the reality is like anyone in the hospital can follow along. The important thing that I really want you guys to take home from this is that this is something that patients want. So 2/3 of the patients that come through the front door of the hospital are using this while they're there. Okay? This is a lot. If you take like your typical patient portal, you got maybe 5 to 10% utilization if you're lucky. And that's in the hospital, not the emergency. Okay? The patients want to know how long they're waiting. They want to see their labs. We can reach out to them with unique messages just for them if they've been waiting longer than an hour and a half or whatever. And we share content that's relevant to them, right? So, hey, 4 or 7 of your labs are back. You can learn about them. If you don't know what a complete blood count is, you can learn what it is. We have little videos and things in here. You can look at your imaging results. And one of the coolest things that we've just started doing, this is what I really like, this is the coolest thing we've built in a while, is that so we have video content that patients can access, right, about their imaging and whatnot, and they can get, they can say, okay, what is this? What's a CT scan, and you know, that kind of thing. And then if you actually look at it, so we have started doing something with generative AI, so OpenAI and ChatGPT, where we've been showing patients their results for a long time. So if a patient has a CT scan and it's completed and the note's finalized, we show that to the patient. There's a federal law that says that happens. There's nothing in the federal law that says you need to have a note that a patient can understand and use, right? So we actually have started doing something which we call basically doctor-to-patient translator. And so we will take something like a broken ankle, right? And instead of it saying, you know, you have like a trimalleolar fracture with minimal displacement of the talar or calcaneal joint or whatever. We actually will translate it for them so that they can read it and make sense of it. It's very popular. The patients really like it. The doctors like it because you don't have to spend as much time explaining it, right? So that's basically some of the stuff that we try to do this kind of stuff. Sorry, I'm having some zooming around issues because of the internet connection here. Just back. And then we spend a lot of our time talking to patients about, towards the end of their visit, about how they're going to get care, how they're going to get linked back into care. So we have elements of the application that are just purely demographic, like who's your PCP doctor, who's taking care of you here. Most patients, believe it or not, don't know who their primary care doctor is. I mean, like, this should not be surprising to you, but many patients have no idea. And in fact, if you look at the data within the electronic health record, about 20% of patients have a correct primary care doctor listed in their electronic health care record in the hospital. And of those 20%, less than half of them know who the guy's name is. No offense, my dad is a family doctor. Like, I love family doctors, but just there's a complete disconnect between what's happening in the acute care setting and what's happening out in the great wide world of primary care, right? Which is why it's so expensive. When I see somebody with a distal radius fracture, and I say, you have a broken arm, I have absolutely no idea if they're part of a DPC, if they're part of an ACO, or any of that stuff. They don't tell me that because of EMTALA. They're worried that I'm going to like somehow treat the person worse if I know they don't have good health insurance or something. So I truly don't even know what to tell this person, right? Hey, you're supposed to go to the care coordinator, your ACO, your primary care doctor, before you go and get some random orthopedist down the street to do your ORIF that's going to cost you $30,000, whereas if you went in network, it would cost you nothing, right? So the patients don't know that. I don't know that. I'm an ER doctor who's cognizant of these things. I promise you none of my colleagues know that stuff. And the hospital is not helping us understand that because they're all fee for service, right? That's not their business model. So anyways, that's what the software does. It just basically keeps people informed. They can ask for things when they're in the hospital, like, I need help with something like that, okay? But because of this audience, I want to talk to you a little bit about what we do with our engagement. So the nice thing about our platform is that because we have 2/3 of the patients in the ER using it, okay? They're literally sitting there using it when they're sitting in the waiting room. And we can send them anything we want while they're there. The hospitals have asked us to send out surveys, like how's it going? We want you to improve our Google reviews. They've asked us to alert care coordinators to come down and schedule them appointments for their broken arm before they leave the building. And we've worked with lots of non-hospital based organizations to help them with their patient panels, because there's a big disconnect between, especially in a capitated environment, between your patient panel and what the people in the hospital know about your patient panel, because it's not on their insurance card, okay? If you come into the hospital and you're a member of a DPC or an ACO or HMO or something like that, your insurance card doesn't convey the information to the hospital that you specifically need a different kind of follow-up resourcing than the average fee-for-service PPO patient. Make sense? And that communication that you may have with the hospital, they may be feeding you data through the HIE to your clinic, and you may be seeing it, and they come back to your office 2 weeks later for a follow-up visit, or whatever it is, but it has to be as needed, right? And you're not necessarily communicating with that patient beforehand. There's nothing reaching out to the patient that says you're special in some way, financially, and you're part of any sort of specific health system. So we've started working with different organizations to do those types of things. And our angle here is that we're already talking to the patient. We already have a relationship with them and their family. So when patients are using our platform, 2/3 of them are sharing with their family members, and when they do, they have 2 other people using it. So it's a patient, their niece, their cousin in California who happens to be a nurse, and everybody's kind of involved in this process. Because we're able to do that, we're able to sort of, I guess you want to call it like build trust with the patient, but effectively we're giving them something they want. They want to see their results. They want to know what their wait times are. They want to be able to communicate with the hospital staff. But because we do that, we can also work with the organizations outside the hospital. So here's something that we use typically when we're approached by hospital-based organizations. Primary care clinics use this. Effectively, what we say is, tell us the patients you, outside the hospital, care about. I want to know which ones you care about. And they may be your whole patient panel, like if you're just a very diligent primary care doctor, you want to be notified when your patients come to the hospital, or it may be in a capitated environment or an at-risk environment, whatever it happens to be, right? And you may have something like this. I know Epic has a feature for this if you're on the same instance of their platform, but I bet most of you are not. And that's just kind of how it works, and you have to be usually working for the health system to get that nice feature. So this is an example of how we talk to patients. Okay, so we talk to patients on a personal level because we know who they are, right? So we'll say, Samantha, your ER doctor recommends scheduling a follow-up care appointment. This is something we built for an ACO in Arizona. They wanted their patients to call them when they leave the hospital, right? So we can communicate to the patients directly because we already have a relationship with them, right? Like I said. So we can tell this patient individually, hey, you are a member of this health organization. I'm not going to say the name of it. Call them. When you need a follow-up appointment, call this person. And in this case, it was a care coordinator. It wasn't a primary care doctor. It wasn't a nurse in the clinic. It was like literally call this person. And they had a special phone number just for that person, right? As you might imagine, like a nurse in your office or a care coordinator, right? So the difference here is it's non-paternalistic. We're letting the patients know that they're special, they have resources that were otherwise unknown to them or unavailable, right? What I've heard a lot in here is sort of like we're wrapping the patient up in a blanket of things that they need. But the missing piece is actually getting the patients and their family members who are using this platform to realize that those things are available to them. So we're getting at them from a different direction. At the same time, if the patient, if the organization we're working with wants us to, we can present other information. If you have a PCP, Mustafa Bana, and he has this phone number like this, or a direct email like this. So like that's the kind of thing, we just do tailored messaging to them. Now, if you're in the hospital for whatever reason, and you have the ability to contract with these organizations, like let's say there's a big ACO in your market that works with the hospital, or the hospital like owns the ACO, right? Or the ACO has big contracts with them. They will sometimes do specific integrations with the hospital's EHR so that the hospital-based social workers and care coordinators can find out when their patients who are capitated come in through the door so they can wrap them up in resources, right? So we do that too, right? So we actually will message the organization, whether they're in the hospital or out, but in this example it's in, and say a person who's a member of this ACO, or whatever you want to call it, MA plan, whatever it is just walked in the door of the waiting room. Like, you want to read about them? You can click here, it's a unique link, and we have effectively built a work list that populates across different hospital facilities for that person. It's built for centralizing those resources, okay? So in this case we have, the top example is, and it can work across different plans. So like you said, you have an ACO, you have different types of groups. You can actually get them all on the same screen. So like let's say you wanted your direct primary care people and one medical and everybody else wants to be part of this because they want to save money and the hospital wants their business. You can put one medical and the specific doctor's DPC and everything in here so that the hospital-based care coordinator knows who to reach out to first. And it's just basically like a work list, okay? And then the last thing that we built, which I think probably going to be the most relevant and useful to y'all, is how do we communicate with people outside the hospital, right? We're already talking to the patients, we're talking to the people inside the building. But a lot of times the people inside the building know what's happening with the patient right then and there, but they don't know the patient. They don't know their family members, they don't know what their needs are, right? So if you want, and this is another thing we do, so we will message your care coordinator through email, and in this example is an SMS, okay? So a member of Spring Health, this is like the generic made-up health plan in the ACO, has just checked into the waiting room. And so we can message people outside the hospital and give them clinical information, similar work list, but it goes across facilities. So if our software is in like 10 hospitals, which it is in some markets, we can tell them, hey, in hospital A, this patient's there, hospital B, this patient's there, okay? So that's basically it. It's not rocket science, but it fills a need within the communication ecosystem of healthcare. And it's care coordination with the patient and with the people outside the hospital. And we've done it in a variety of ways to varying degrees of success depending on the resources that lie to us. And in some cases we can do things with AI. We can do natural language processing. So my old employer cut a deal with a few MA plans where the MA plan said we need any one of our members who comes to the ER to be followed up on 7 days, primary care, okay? Either virtual visit or in person. And they couldn't find these patients because they were relying on data coming from the plans. And they didn't have care coordinators like kind of tracking these people. So effectively what we did was we said, okay, is this person on this specific list? We ingested the list from the system. They said these are the 5% of our MA patients we're watching. We concatenated with the data that we get from the electronic health record, and we created effectively a suite of alerts that go out to the patient, go out to the hospital care coordinator, and then to the care coordinator and the nurses that do navigation for essentially the private physician group that cut that contract. Okay, so this is an example of things we've done that I personally really feel strongly about because it works really well if you can use AI. Because basically what you're doing is you're reading doctor's notes, you're inferring need from them in different ways. So we see this person has a specific type of insurance, we pulled in information that they're part of an ACO, and then they fall into a high-risk profile or certain medical terminology was used in their notation that we can pull out using effectively NLP, and then we can put them onto a work list for someone outside the hospital to interact with. So I could talk about a million other things, but I'm sure y'all have questions.